Thank you very much. I hope you can hear me now again. So I will continue with this topic about biotics. So Professor Ivan van den Plas covered human milk oligosaccharides. I previously covered prebiotics also, but also symbiotics and postbiotics. But now let me focus on probiotics in pediatrics, and it will be a 2020 update. You have already heard all where my scientific heart belongs, so I will just repeat as vegan, ISAP, and I really like evidence-based medicine. So we will focus on probiotics. People are asking all this question, probiotics, myths or miracle? Are probiotics really that good for your health? Probiotics, panacea, or just a big fad? Why there is such an interest in probiotics? And I will try to cover at least some of those questions. What are probiotics? There's a definition which comes from ISAP, already published 2 years ago, live microorganisms that, when administered in adequate amounts, confer a health benefit. And each part of this definition is important. The microorganism has to be live. The dose matters. And of course, like in every definition, health benefit has to be demonstrated. We know that not all probiotics are equal, so it means that each probiotics has to be evaluated separately. And why it's so? And one of the reasons is that if you look at the mechanism of action, why there are some widespread mechanisms among studied probiotics, like for example, colonization resistant or acid and short chain fatty acid production. There are some species level frequent mechanisms, but what is really important that there are some rare strain specific effects, like for example, immunological effects. What differentiate one probiotic from another is how it influences what is the impact on the immune system. And that's why it's so important to look at each probiotic separately. What is new in 2020? This is a paper which summarized criteria to qualify microorganisms as probiotics in food and dietary supplements. And a number of ISAP members, or the people who are contributing to ISAP, put this paper together. So let me just show one slide. The candidate probiotic strain has to be well characterized. We really have to know which microorganism we are discussing and the genome sequence. The best is to know the genome sequence of this microorganism. Safe for intended use, that's absolutely obvious. At least one positive relevant human study, because even in the definition, you can hear that the health benefit has to be documented. And the product delivers study dose viable until end of shelf life. So the dose again is important. And if it's okay for all of those, then you may say this is a probiotic strain. If not for any of those, it's not a probiotic. This comes again from ISAP, how to choose a probiotic. So I already mentioned genus, species, strains, the characteristics is important. Expiration date is important. Storage needs, not all of them has to be in the refrigerator, and some of them in the room temperature. Those I already commented. And last but not least, I will repeat evidence. And this is what I would like to focus now. Some few years ago, I had a privilege to contribute to this paper. What are the indications for using probiotics in children? I will not cover all of them. I will cover some of them, and I will try to explain why. And I will start with acute gastroenteritis. And of course, everyone agrees that the key treatment is rehydration. Oral rehydration therapy is one of these for diarrheal diseases, is a success story. Until now, 500,000 of children below 5 years of age may die during the diarrhea. However, this is much less than it was in the 80s, 4 to 5 million. And this is really mainly, not only, but mainly to oral rehydration solution. But ORS remains underused, and this is despite the proven efficacy. And this is because it does not reduce vomiting, it does not reduce frequency of bowel movements, fluids loss, duration of illness. And as a consequence, there is interest in safe, effective, and inexpensive agents as an additional treatment. including probiotics. And until 2020, most scientific societies agreed that the use of selected probiotics with documented efficacy may be considered in the management of acute diarrhea in young children, of course, only as an adjunct to rehydration therapy. But then, quite recently, 2 RCTs were published in a New England Journal of Medicine, and they showed that probiotics are no better than placebo for acute gastroenteritis. Large trial with altogether almost 1,800 participants. And one of these probiotic, one of those studies, which was probiotics LGG, Lactobacillus rhamnosus GG, which is often in the guidelines. So, well, Houston, we have a problem. Yes, indeed, there is a problem. And within the ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition, we decided to update, it was in a working group on probiotics of ESPGHAN, we decided to use, to update what is known on the use of probiotics for the management of acute gastroenteritis. And Professor Van Vandenplas, who was a speaker, previous speaker, he was also contributing to this paper. When we are working, just very briefly, the recommendations were formulated only if at least 2 randomized controlled trials that used a given probiotics were available, and there were no recommendations in probiotics in general, because we strongly believe that, and I already repeated, and it's not only us, many other organizations, that each probiotic has to be evaluated separately. Like, we are not talking about antibiotics in general. We are always speaking about a specific antibiotic. So exactly the same here. If only 1 randomized controlled trial was available, regardless of whether or not it showed a benefit, we did not formulate any recommendation. And if the strain specification was not given, also we did not formulate its recommendation. And I already mentioned that I showed you that one of these criteria for probiotics is that we know exactly, that we know the characterization, the specification of the microorganism. We identified 16 systematic reviews and meta-analysis published since 2010, including 7 strain-specific meta-analyses. Altogether, there were 150 randomized controlled trials, and only some of these randomized controlled trials included in the systematic reviews overlap. Of course, there are, every now and then there is a good explanation why it is so, but this is just for your information. And on this slide, you can see only 6 probiotics, single or combinations, that were evaluated in 2 or more randomized controlled trials. So many studies, and only very few, there was repetitive studies. And you know, science is about the repetition of the results. So it really would be nice to see repetitive studies. They are the summary, and I'm just showing you the summary for one of the outcomes that we looked at. It was the duration of diarrhea, and generally there was a reduction in the duration of diarrhea. However, when you look for one of the probiotics, Lactobacillus rhamnosus, there was only reduction in the duration of diarrhea when we evaluated all of the trials. But when we looked only at studies with a low risk of bias, there was no significant difference. There was, of course, a lot of discussions about how to interpret this data. I will make a long story short, and I will just show you the final recommendations. So as you can see, we have four positive recommendations, and these are for Saccharomyces boulardii, Lactobacillus rhamnosus GG, Lactobacillus reuteri DSM 17938, and the combination of Lactobacillus rhamnosus and this particular Lactobacillus reuteri. You know now that all these numbers, letters and numbers are important. And the order is based on the number of trials available. So it's not that we are saying that one is more important than the other. There are conditional recommendations with low to very low quality of evidence. We also provided 2 negative recommendations. One was strong and one was conditional recommendation. For all these positive recommendations, we also provided the doses in the paper, and the duration of treatment is usually based on other previous studies, and it's 5 to 7 days. So these are the general conclusions from our paper. But there's another paper which looked at the similar topic, the use of probiotics generally, but including acute gut diarrhea, and it comes from AGA, American Gastroenterology Association. And here for children in North America, the conclusion is that in children with acute infectious gastroenteritis, we suggest against the use of probiotics. Conditional recommendation with moderate quality of evidence. So we do see differences between ESPGHAN and AGA documents. Both were made based on meta-analysis of randomized controlled trials, different number of studies which were included for the analysis, target population in our ESPGHAN working group guidelines, it was children in Europe, but all evidence was considered for AGA. They were mainly focusing on children in North America. Certainty of evidence, in our case, low to very low, AGA moderate, and the strength of recommendation in both, for both recommendations, conditional, but for or against. For these AGA guideline, the recommendation, the two most important papers, both in North America, are these two negative studies published in New England Journal of Medicine, which show that probiotics are no better than placebo for acute gastroenteritis. Of note, more than 60% of the study population was vaccinated against rotavirus, which really differs those studies from previous studies when which were conducted mainly when the rotavirus vaccine was not so common and the children were usually not vaccinated against rotavirus. Whether it matters or it does not matter, I don't know, but I think it's something for consideration. But anyway, we do have this conditional recommendation for or against. So what is the interpretation? And here is the interpretation from the Great Handbook. It's a very similar interpretation, conditional recommendation for an intervention and against an intervention. It's the same interpretation. Different choices will be appropriate for different people. Clinicians could help each patient make decisions consistent with the patient's preferences. What is new? So I showed you what are the ESPGHAN working group on probiotics recommendations and AGA. And this is very new, Cochrane review, which looks at probiotic for treating acute infectious diarrhea. And the conclusion was on probiotics in general. So I'm not talking about any specific strain. Probably make little or no difference for the number of people who have diarrhea lasting 48 hours or longer. It's uncertain whether probiotics reduce the duration of diarrhea, and this analysis is based on large trials with low risk of bias. And here, please remember, they were not looking only in children, but generally in regardless of the age, even if the majority of trials were conducted in children. And what is interesting, so probiotics in general, there is no very favorable conclusion. However, if you look at the individual studies on the analysis on particular strains like Lactobacillus GG, Saccharomyces boulardii, Lactobacillus reuteri, you will see that is this strain-specific meta-analysis. There was also always a reduction in the duration of the diarrhea with a huge heterogeneity like all other meta-analysis. So I showed you what is the evidence. So the question is probiotics and acute diarrhea, to give it or not to give it. And this is my personal conclusion, that specific probiotics may be beneficial, although not essential, in the treatment of acute diarrhea. The use of certain probiotics with documented efficacy may be considered in the management of acute diarrhea in young children. And I think that when endorsed, the strains most often recommended include LGG, Saccharomyces boulardii, and Lactobacillus reuteri, DSM 17938. So once again, may be beneficial, although they are not essential. So I covered probiotics and acute gastroenteritis, and the reason why I decided to cover it is because there are new data, new recommendation, and also new Cochrane review. Now let me move to another indication, which is the use of probiotics for preterm infants and necrotizing enterocolitis. And here, of course, we are not discussing reduction in the duration of diarrhea by 1 day, but we are really talking about death and life. And we know that very low preterm infants, very low birth weight infants, preterm infants, there's a high risk of, at least in some setting, of necrotizing enterocolitis. And the reason I have chosen this particular condition is that we have again, guidelines from ESPGHAN and from AGA. And as you will see in a moment, they differ. So I will start with the ESPGHAN document. These are guidelines developed by our working group on probiotics and prebiotics, but also with the ESPGHAN Committee on Nutrition. So a lot of people contributed to this document, and it took us more than 3 years to come to the final conclusions. A number of clinical questions was raised here, and we did try to address all of them, and you can find answers to all of them in the paper, which is open access, so you can go. It's published in the JPGN, Journal of Pediatric Gastroenterology and Nutrition. But one of the most important questions was, should probiotics be used in preterm infants? And if yes, which probiotics, single or combination, should be used and what dose? And so we have provided some positive recommendation, and if all safety conditions are met, the positive recommendations is for LGG and the combination of Bifidobacterium infantis BB02, BB lactis BB12, and Streptococcus thermophilus TH4. Question mark, we did not formulate a recommendation for or against. They were for those two probiotic, one single and one combination. And we also provided negative recommendation for Bifidobacterium breve BBG001 and Saccharomyces boulardii. But let me focus on something which is positive. So again, if all safety conditions are met, LGG, and we provided the dose which is recommended based on the studies, and for this combination of 3 strains. And again, we provided what should be the dose. As I already mentioned, there are again differences between ESPGHAN and American Gastroenterology Association guidelines. We provided for, nor against, and against recommendations. American Gastroenterology Association listed more strains that we listed with a positive recommendation. They did not find anything, they did not formulate any negative recommendation. So we do have a problem in a way, because while both were based on pairwise systematic reviews and network meta-analysis, because this was a methodology used in both guidelines, their conclusions differ. And this is, of course, problematic always for people. So what to do? So the good message is that in both guidelines, there's one probiotic that was recommended by both societies. And as you can see, this is LGG ATCC 53103. So my personal opinion is that if you have doubts what to choose, just to choose the probiotics which is recommended by both societies, if it is, of course, available in your settings. And very briefly, so I briefly commented on the probiotics for acute gastroenteritis, for necrotizing enterocolitis. Again, I have chosen it because there are recent recommendations and the recommendations differ. And I have also chosen infant formula supplemented with probiotics. And this is because it's very often a question which is very often asked. This is a systematic review which we published already together. I published together with my colleagues from our team already some time ago. And at that time, we found that there was a number of probiotics studied. There is some positive effect, depending, of course, on the strain, like reduced GI infections, lower frequency of colic, etc., etc. But again, I would like to call your attention that at least some of those strains can reduce the use of antibiotic prescription. And I'm going back and again to this outcome, because I think it's really important in the context of the effects of antibiotics on the microbiota. So my summary for this part of presentation, based on the literature: no safety concern with regard to gross and adverse effects. Some favorable clinical effects are possible, and I showed you, and the efficacy and safety should be considered for each probiotic supplemented formula. So it's difficult to give one single recommendation which will be applicable to all kinds of formulas. So I showed you some of the evidence on some of the use of probiotics, but even if the best evidence guidelines are available, they do not automatically lead to improved health outcomes. Even more, they may differ, which makes life even more difficult. But anyway, there are so many barriers between evidence and clinical outcome, as you can see on this slide. And there is a role for physician, and there is a role of patient. And with this, I would like to finish and to thank you very much for your attention.